Your heart beats about 2.5 billion times in a lifetime. Every single beat depends on a molecular event called excitation-contraction coupling. It's how electricity becomes force. Let's zoom in. Cardiac muscle cells, cardiomyocytes, are short, branching, and connected end-to-end by structures called intercalated discs. These discs do two jobs. Gap junctions let ions flow directly from cell to cell, which means the entire ventricle depolarizes as a single electrical unit, what we call a functional syncytium. Desmosomes provide the mechanical glue so that when cells pull, they don't tear apart. Inside each myocyte, the contractile machinery is organized into sarcomeres, the repeating units of actin and myosin filaments. Running perpendicular to the cell membrane are deep invaginations called T-tubules. Wrapped around the sarcomeres is a specialized calcium storage organelle called the sarcoplasmic reticulum. Here's how a contraction actually happens. When an action potential travels down the sarcolemma and into the T-tubule, it opens voltage-gated L-type calcium channels, also known as dihydropyridine receptors. A small amount of calcium flows into the cell from the extracellular space. That small trigger of calcium binds to ryanodine receptors, specifically RyR2, on the sarcoplasmic reticulum, which fling open and release a massive flood of stored calcium into the cytoplasm. This is calcium-induced calcium release. A little calcium in causes a lot of calcium out of storage. The cytoplasmic calcium concentration rises from about 100 nanomolar to 1 micromolar, a 10-fold increase in free calcium. That calcium binds to troponin C on the thin filament. Troponin C changes shape, pulls on troponin I, and shifts tropomyosin out of the way. This exposes the myosin binding sites on actin. Myosin heads, primed with ATP, bind to actin, pull, release, rebind, and pull again. The sarcomere shortens, the heart contracts. Relaxation requires getting calcium out of the cytoplasm fast. Two pumps do most of the work. SERCA2, sarcoplasmic endoplasmic reticulum calcium ATPase, pumps calcium back into the sarcoplasmic reticulum for the next beat. The sodium-calcium exchanger, NCX, pulls 3 sodium ions into the cell in exchange for pumping 1 calcium ion out. A small amount is also extruded by the plasma membrane calcium ATPase. SERCA2A is regulated by a protein called phospholamban. When phospholamban is unphosphorylated, it inhibits SERCA2A. When sympathetic tone rises and beta-1 receptors activate, protein kinase A phosphorylates phospholamban, releasing its inhibition. SERCA2A pumps faster, calcium clears faster, and the heart relaxes faster. This is called positive lusitropy, faster relaxation. And it's just as important as positive inotropy during exercise, because a faster heart has to refill faster. Clinical anchor, digoxin, is a classic cardiac drug that works by exploiting this system. Digoxin inhibits the sodium-potassium ATPase. That raises intracellular sodium. With more sodium inside, the sodium-calcium exchanger has less gradient to work against and pumps less calcium out of the cell. Calcium accumulates in the sarcoplasmic reticulum. The next beat releases more calcium and contracts harder. That's positive inotropy, increased contractile force, without any change in heart rate or preload. On the other end, anything that drops extracellular calcium, severe hypocalcemia from massive transfusion, pancreatitis, or tumor lysis, weakens contractions because there's less trigger calcium to start calcium-induced calcium release in the first place. That's the molecular story of a heartbeat. Electrical signal in, calcium flood out, filaments slide, heart squeezes. Every beat, every second.